Welcome, Zoo Assembliers! My name is Zouk Azalishvili and I'm the founder of Zoo Assembly. Zoo Assembly is an online podcast for the highest yield basic science and clinical knowledge tested on USMLE Step 1 and USMLE Step 2 CK. The information discussed in this podcast is intended only for educational purposes. It's not intended to prevent, diagnose, or to treat the medical conditions in real clinical practice, nor is it intended to reflect the policy and the guidelines of various health institutions. Simply put, we serve you to butcher your step exams. Please subscribe to our podcast, Facebook, Instagram pages, and the YouTube channels down below in the description of this episode so that we keep you tuned for the news at Zoo Assembly. Now, let's start rolling. We are continuing our psychiatry series, and the first topic that we are going to discuss today is the personality and personality disorders. Before we discuss the personality disorders in detail, let's define the difference between the personality trait and the personality disorder. All of us have our own personality traits, and that's totally normal, and this is what makes us all unique. The personality trait is the feature of the person by which that particular person interacts with the world or sees the world. The thing about personality trait is that the personality trait is adaptive. In other words, we can literally adapt to the different situations and the different environments. In contrast, the personality disorder is the maladaptive pattern of behavior. In other words, the patients with personality disorders cannot control how they react to the different situations. They have this very rigid, extremely rigid and maladaptive pattern of behavior. In other words, they behave the same way in all the situations and with everyone. And you can imagine that this rigid behavior can cause significant problems in the patient's personal life and occupational life. But the important thing about patients with personality disorders is that they are mostly EgoSyntonic. Okay, I think we have already explained the difference between EgoSyntonic and EgoDystonic attitude, but could you please remind me what the word EgoSyntonic means? Exactly. When we say that the person is EgoSyntonic, we mean that they are in concordance with their own ego. In other words, they like what they're doing and they don't see that there is any kind of problem with their behavior. In contrast, the EgoDystonic behavior or EgoDystonic attitude means that the person is in discordance with his or her ego. Therefore, the patient acknowledges that there is some problem with his or her behavior. And as we already mentioned, almost all personality disorders are EgoSyntonic, and they usually present by early adulthood. That's another high yield point to expand on. Officially speaking, one cannot diagnose the person with a personality disorder before the age of 18. The reasoning behind this recommendation is that the people are developing their character and their personality until the age of adulthood. Therefore, they may manifest the traits of the different personalities or personality disorders, but this does not necessarily mean that they have a particular personality disorder. And you will see the importance of this notion especially when we discuss the antisocial personality disorder. Okay, now in order to make personality disorders very easy to remember, DSM-5 has a very helpful way of organizing the personality disorders. There are three clusters: cluster A, cluster B, and cluster C. And if we wanted to summarize each of these clusters by one word, then we could use the first aid mnemonic, which proves very helpful for me personally. This mnemonic sounds like this: weird, wild, and worried. Weird for cluster A personality disorders, wild for cluster B personality disorders, and finally worried for the cluster C personality disorders. Okay, now that we've talked about the difference between the personality trait and the personality disorder, let's jump to discussing the specific personality disorders. And the first cluster that we're going to discuss is the cluster A. So let's do it. The cluster A personality disorders include paranoid personality disorder, schizoid personality disorder, and the schizotypal personality disorder. And here is another very helpful first aid mnemonic which I'd like to remind you of. The mnemonic that helps us remember the key traits of each of these personality disorders. So for cluster A, the mnemonic is accusatory, aloof, and awkward. So accusatory is for paranoid personality disorder, aloof is for schizoid personality disorder, and awkward is for schizotypal. Let's start with paranoid personality disorder. If I wanted to summarize this disorder with one word, that would be mistrust to everyone in the world. Patients with paranoid personality disorder cannot trust people, and they read hidden meanings and ulterior motives in in very benign and in very pleasant gestures by the other people. They are very hyper vigilant. They always think that other people are out to get them. But here's the thing, they are not delusional. The high yield thing to remember about the cluster A personality disorders is that although these patients are odd and eccentric, they have an intact reality perception. They understand what reality is and what is not. This is in contrast to psychotic patient. Let's say the patient with schizophrenia. Patients with psychosis, regardless of whether the psychosis is related to schizophrenia or not, cannot distinguish the psychotic symptoms from the reality. But again, this is not the case for the cluster A personality disorders. Additionally, patients with paranoid personality disorder are very cynical about the world, and they may be very cynical about the close and very affectionate human relationships. The reason being is that they don't believe that such trust and love and affection can exist in between the human beings. Okay, let's move on to the schizoid personality disorder. Patients with schizoid personality disorder are loners, but they love the way they live. What I'm trying to say here is that although they are socially withdrawn for most of the times and they prefer doing things on their own, they enjoy solitude. They don't think that they lack human relationships. They like being alone, they like doing things alone, and additionally, the patient with schizoid personality disorder may have the limited emotional expression. It also makes sense. Our emotional expressions are developed and crafted by interacting with other people. Therefore, if one restricts their interactions with other people, then the emotional expression of that person will also be limited. Additionally, patients with schizoid personality disorder can be indifferent to other people's opinion. Right. And the final cluster A personality disorder is the schizotypal personality disorder. I know we have talked about it when we discussed schizophrenia and schizophrenia spectrum disorders, but still, let's expand on this disorder here. Well, schizotypal personality disorder is on the spectrum of schizophrenia related disorders. However, again, in contrast to schizophrenia, schizotypal personality disorder is not characterized by psychosis. They have an intact reality perception. And patients with schizotypal personality are extremely eccentric. They look eccentric, they may talk eccentric, and they may have the odd beliefs and they may have the magical thinking. They may be relating the they may be relating their daily events to the magical events happening in the world. So in this question stem, patient with schizotypal personality disorder will be someone who, let's say, believes that, I don't know, the diamonds or the stones that he or she is gathering helps him maintain connection with the different galaxies or something. I'm not trying to insult anyone. Certainly, this example was not intended for this. But what I'm trying to say here is that patients with schizotypal personality have very, very eccentric beliefs. So the baseline is, if you read the question and if you think that the patient's behavior, the way of clothing, and beliefs are very weird, there's a high chance that you are reading the question about the schizotypal personality disorder. And finally, what I'd like to say about the cluster A personality disorders is that they are genetically associated with schizophrenia. Okay, now let's move on to the cluster B personality disorders. The patients with cluster B personality disorders can be very dramatic. They may have the outbursts of their emotions and they can have very erratic behaviors. Cluster B personality disorders have genetic association with the mood disorders and the substance abuse as well. And just like we mentioned the mnemonic for cluster A personality disorders, let's do the same for cluster B. So for cluster B personality disorders, mnemonic goes like this: bed, borderline, flamboyant, and must be the best. You notice the B's in these four words or phrases, right? So when we say bad, bad is for antisocial personality disorder. The word borderline indicates borderline personality disorder. The word flamboyant is for histrionic personality. And finally, the phrase must be the best indicates the narcissistic personality disorder. Let's first start with the antisocial personality disorder. It's called antisocial because patients with antisocial personality are against people. What I mean here is that they don't care about the rights of other people or other beings like animals as well. And their record may show criminal behaviors and they may be characterized by very impulsive and very hostile behaviors as well. So this will be someone who constantly gets into fight, someone who can manipulate people to do what they don't want to do. Let's say that the person with antisocial personality disorder manipulates the other people to engage in a fight that they don't want to, or engage in a sexual intercourse or sexual behaviors that they don't want to. What I'm trying to say is that patients with antisocial personality are very manipulative. They can earn the trust of other people and then they can manipulate those people and use them for their own good. Antisocial personality disorder is more common in males than in females. And here comes the age cutoff, which is very high yield for antisocial personality disorder. In order for the patient to be diagnosed with antisocial personality, she or he must be at least 18 years old. And this person must have the evidence of conduct disorder before the age of 15. Okay, now that we've mentioned the conduct disorder again, could you please remind me what conduct disorder is from our previous episodes? Absolutely. Conduct disorder is the antisocial personality disorder in people less than 18 years old. In other words, these two psychiatric diagnoses have the same, almost identical signs and symptoms, but the major difference is the age. If person is less than 18, we cannot diagnose them with antisocial personality disorder. But if there are the characteristic signs and symptoms, then we can diagnose him or her with the conduct disorder. So again, the patients with antisocial personality disorders are sociopaths. Now the next cluster B personality disorder is the borderline personality. Borderline personality, in contrast to the antisocial personality, is more common in females than males. These are the patients who have super unstable mood and therefore super unstable personal relationships. If I had to summarize the borderline personality disorder with one phrase, I would say the phrase fear of abandonment. Patients with borderline personality disorder commonly have the history of unstable and untrusting relationship with their parent. Maybe the parent used to neglect the patient, or maybe the parent was absent during the significant milestones of the patient. And then they project this fear of abandonment to all the relationships that they have in the future. Borderline personality disorder patients can be very impulsive, and they are characterized by the tendency of self-mutilation and suicidality. Let's imagine a couple and the girlfriend, let's say that the girlfriend has borderline personality disorder. And let's suppose that there is a tension between their relationship and they are about to break up. Now, what the patient with borderline personality disorder may do is that she may call the boyfriend and she may threaten him to kill herself or to self-mutilate herself if he does not make up with her. Additionally, patients with borderline personality have the sense of emotional emptiness. Regardless of how deep and how intense their relationships are, they feel emotionally empty. And the final high yield point, sorry, it's not the final, but still, one of the high yield points about the borderline personality is that the major defense mechanism that they use is splitting. Okay, now could you please tell me what this splitting is all about? You are amazing. Splitting literally means splitting the world into good and bad in your mind. Patients who use splitting as their defense mechanism see some people as angels and other people as demons. They see the world in white and black colors. There is no gray zone for them. And this defense mechanism is very commonly employed by patients with borderline personality disorder. However, please don't get me wrong. I'm not saying that splitting is characteristic for only the patients with borderline personality. Anyone can use splitting while they are dealing with some sort of stress. However, patients with borderline personality disorder preferentially use this defense mechanism. And let's also mention the treatment for borderline personality disorder. If you have noticed, we have not talked about treatment of personality disorders so far, and there is a reason for this. In the beginning, we mentioned that patients with personality disorders are egosyntonic. In other words, they don't think that there is any type of problem with them. And in order for any type of psychotherapy to work, the patient should realize that there's some problem with their behavior, and they should be willing and ready to help themselves and to correct their behavior. This is why the psychotherapists usually don't treat the patients with personality disorders. Let me get it more correctly. Patients with personality disorders usually don't go to the psychotherapist to treat their personality disorder because they think that everything is fine. They think that the problem is in the world. Problem is in the other people rather than in themselves. However, there is a very specific type of psychotherapy which has proven to be the best treatment option for borderline personality disorder. And this type of psychotherapy is dialectical behavioral therapy, or DBT. Dialectical behavioral therapy is not used only for borderline personality. It can also be used for other psychiatric diagnoses like major depressive disorder. However, again, if the question asks what is the best treatment option for someone who has borderline personality disorder, then the answer will be dialectical behavioral therapy. Right, now let's move on to the histrionic personality disorder. Patients with histrionic personality are attention seekers. These are the patients who have extremely dramatic behavior. They may talk loudly, they may laugh loudly, and they may be over expressive in terms of their emotions. And even more, patients with histrionic personality disorder can sometimes be sexually provocative and sexually promiscuous. The case that commonly comes up on the boards and also on the other tests is when, let's say, the female goes to the male physician and the female is dressed in a sexually provocative way. She compliments the doctor about, I don't know, his clothing, and she tries to get the doctor into the romantic relationship. The patients with histrionic personality disorder have shallow and very labile emotions. And if the doctor encounters the patient with histrionic personality, then the doctor may need the chaperone for the future appointments with this patient, or if the patient does not stop to act in a provocative way, then the physician may need to refer this patient to the other physician as a last resort. Okay, and now finally, the last personality disorder from the cluster B is the narcissistic personality disorder. And I think the name itself is pretty much self-explanatory. These patients are narcissists. They think that they are invincible, they are grandiose, and they think that they are entitled from God in a special way. Additionally, they lack empathy for other people. For example, if someone with a narcissistic personality disorder hears about somebody else's failure or hardship, then he or she won't truly feel any empathy for that person, because the patient with narcissistic personality disorder perceives the other people as competitors. And this is why this patient can also be envious of the other people as well, especially the successful people. Patients with a narcissistic personality require excessive admiration. They want people to constantly praise them. They want people to constantly talk the positive things about them. And then if they come across the criticism directed towards them, they respond with rage, with an absolute rage and defensiveness. The criticism is a way of growth, right? And some people, some of us may not like criticism, but what I'm saying here is that narcissistic patient responds with the sheer rage, because he or she perceives the criticism as an insult, not as an opportunity to grow. The interesting thing about patients with a narcissistic personality disorder is that they may have, and they often have, the fragile self-esteem inside. Okay, now the last cluster of the personality disorders is the cluster C. Now let's move on to that. The patients with cluster C personality disorder are either fearful of something or people, or they are very anxious. And interestingly, the cluster C personality disorders are genetically associated with the anxiety disorders. Now, there's also a mnemonic for cluster C personality disorders, and the mnemonic sounds like this: cowardly, obsessive compulsive, and clingy. Now, the word cowardly indicates the avoidant personality disorder. Obsessive compulsive indicates obsessive compulsive personality disorder, not the obsessive compulsive disorder. They are not the same things. And finally, the word clingy indicates the dependent personality disorder. Let's start with the avoidant personality. These are people who literally avoid interacting with other people due to fear of rejection and criticism. They are very sensitive to rejection and criticism. They may shut themselves down if someone criticizes them or laughs at them. They are socially inhibited and very timid. And the patients with avoidant personality disorder have the constant sense of inadequacy. They may be asking themselves, am I good enough for this? Am I smart enough for this? Am I beautiful enough? So they think that they are not enough for something or for someone. But avoidant personality disorder patients crave for the relationships with other people. They want to have relationships, but they are so afraid of rejection and criticism that they don't dare to start the relationship. And this is in absolute contrast to the patient with schizoid personality disorder. Someone with schizoid personality disorder is totally fine when he or she is alone with herself or himself. The patient with schizoid personality disorder does not crave for relationships. The schizoid personality patient does not care about the relationships. Okay, now that we've talked about the avoidant personality, let's move on to the obsessive compulsive personality disorder. Again, I would like to emphasize the point that obsessive compulsive personality disorder is absolutely different from the obsessive compulsive disorder. As you remember from our previous episode, obsessive compulsive disorder is an anxiety disorder which is characterized logically by obsessions, which are intrusive thoughts or emotions, and then compulsions, which are behaviors, either physical or mental, which at least partly relieve those obsessions and anxiety. Patients with obsessive compulsive personality disorder do not have obsessions or compulsions. These are simply the people who love order in their lives. They are perfectionists, they love order, and they love to control everything and honestly everyone in their lives or around them. The patients with OCPD are EgoSyntonic. In other words, they like the way they are and they don't think there is any problem because their behavior is consistent with their beliefs. This is another difference between OCPD and OCD. As we already mentioned in the previous episodes, the patients with obsessive compulsive disorder are ego-dystonic. They don't like those obsessions. They don't like the intrusive thoughts and emotions, and they want to get rid of them. Okay, yes, so as we already mentioned, patients with OCPD is obsessed with order and perfectionism. So they usually put their maximal effort to everything that they do. And if they see that somebody else is not working their ass off or is not putting the maximal effort into the mutual responsibility, they may get really, really upset, even to the level of confrontation and fight. Not the physical fight, but there may be a quarrel. Okay, and the final cluster C personality disorder is the dependent personality disorder. And again, I think the name itself explains what this diagnosis is all about. These patients, adult patients, are super dependent on other people for almost every decision in their lives. They need the constant support and they need someone in their lives who will make decisions for them. And this is why the patients with dependent personality disorder have low self-confidence. They may need somebody else to decide what to eat for a dinner. They may need somebody else to decide when or where to go on a vacation. And again, dependence on somebody else spreads on almost all the decisions in their lives. You can imagine that such patients are very prone to getting stuck in abusive relationships. Other people may take advantage of the patient's dependent personality and they may get into a relationship with such patient in order to take control of them. So in order to summarize the dependent personality disorder, we can say that these patients are very submissive. They need support and they need someone who will make decisions for them during their life. Okay, now we're done with the personality disorders. Let me tell you about Match a Resident. Match a Resident is an organization that helps residency applicants find the perfect residency programs for them. Although it's particularly helpful for international medical graduates, anyone is welcome to Match a Resident. It is trusted by over 150,000 international medical graduates for over 17 years. Match a Resident gives you detailed information about each program's requirements, such as visa status, USMLE scores, and more. Match a Resident annually updates these requirements through in-person conversation with program coordinators every year to give you the newest information possible. This way, you invest your time and money in the residency programs where you have high chances of matching. To find out more about this amazing organization, check out the website www.matcharesident.com. Match a Resident is the path to your success. Now we'll move on to malingering, factitious disorders, and somatic symptom and related disorders. Let's start with malingering. Malingering is when the person fakes the symptoms or an illness in order to gain a secondary or external gain. Now let's elaborate on this explanation. The symptoms of the malingering patient are intentional. So they know that they are causing the symptoms on their own, and their motivation is also intentional. In other words, patients with malingering know why they are causing their symptoms. They have the secondary or external gain in mind, which needs to be obtained by those fabricated symptoms. The patient with malingering may totally fake or exaggerate the disorder that he or she has. And the secondary gain or the external gain is something external, something materialistic, but not necessarily the money. So, I mean, the secondary gain may be to avoid work or to avoid going to the rehearsal or the sports practice. It may also be obtaining the compensation. Now, let me tell you a story, my personal story. I need to confess with you in malingering. I have done malingering once in my life. I was in a rugby camp, and for starters, I don't like rugby. I really didn't want to be there, but for some reason, I just happened to be there. And I had to play rugby, but I really didn't like it. So then I accidentally slipped off and fell down. That was actually real. It wasn't planned, and I hurt my ankle very mildly. It was almost nothing. However, I exaggerated it. I just acted as if I was having excruciating pain, and then they let me leave the camp. So my father just came there with a car, and we went home. Yeah, this is my confession, and I realize now that this was a classic example of malingering. Patients who do malingering are very non-compliant with the treatment or the follow-up with the diagnostic tests, and it makes sense. They either do not have any real symptoms or they exaggerate their symptoms. Therefore, if they go on the follow up appointments and if they undergo the diagnostic tests, then the doctors will eventually find out that he or she is literally lying. This is why they are non compliant. And plus, the complaint of malingering stops immediately after the person has the secondary or external gain. So if we go back to my example, once I left the rugby camp, I no longer pretended that I had a sore ankle. I just continued with my life. And this concept is very different from factitious disorder that we are going to discuss right now. What I'm trying to say is that complaints do not stop after the patient with factitious disorder obtains a specific gain that they're interested in. Now let's move on to the factitious disorders. Factitious disorder is characterized by intentional symptoms but unconscious motivation. In other words, the patient with factitious disorder know that they are causing their own symptoms, but they don't understand why they're doing this. So their motivation is unconscious. And they usually create or fabricate the physical symptoms and the psychological symptoms. And the main motivation for them is to assume the sick role. Because if they assume the sick role, then they get all the attention from the healthcare workers and they also get the sympathy. And this is the primary gain, also known as the internal gain. If you remember, when we discussed malingering, we mentioned the secondary gain or external gain. This was literally something external, something materialistic. But when we talk about factitious disorder with its primary or internal gain, this gain is really internal. It's emotional and it's personal. So these people try to not to feel alone by inflicting those symptoms. They want to just fill up that sense of loneliness in themselves by assuming the sick role. Factitious disorder exists in two forms. One can have factitious disorder imposed on self or factitious disorder imposed on another. And as the name implies, factitious disorder imposed on self means that the person inflicts the symptoms or inflicts an illness on herself or himself. It's also known as the Munchausen syndrome. Patients with factitious disorder imposed on self usually inflict the physical signs and symptoms. They may intentionally, I don't know, sprain their hand or ankle. They may complain about the chronic headache or tension in their body. And patients with factitious disorder imposed on self usually have a history of multiple hospital admissions and multiple, even invasive diagnostic tests. They are willing to undergo any of those tests as long as they are among the doctors and as long as they get enough sympathy and attention. Factitious disorder in general is more common in women and also in healthcare workers. Now, factitious disorder imposed on another is also known as the Munchausen syndrome by proxy. This is when the person inflicts the onus, usually on a child or an elderly patient that the person takes care of. And then the motivation here is that the person who does the factitious disorder wants to be acknowledged by healthcare workers that she or he is taking care of that child or an elderly. They want to assume a sick role by proxy. And factitious disorder imposed on another is actually the form of child abuse or the elderly abuse. Therefore, it is mandatorily reportable. If you literally physically inflict the signs and symptoms of an illness on a child or elderly, that's clearly an abuse, right? But then the question is, if you just fabricate the story about the illness of a child or an elderly, is this still an abuse? In reality, the answer is yes, it is still an abuse, because if you fabricate a story, if you make up a story about someone else's illness, then the healthcare workers will try to diagnose the patient, will try to find out the extent of the disease, and for that they need to run the diagnostic tests. What I'm trying to say is that the fabricated story can expose either a child or an elderly to the unnecessary tests. And this is also the form of child abuse. Now we'll move on to the somatic symptoms and related disorders. Finally, let's move on to the somatic symptom and related disorders. There are three disorders in this group. We have somatic symptom disorder, conversion disorder, and illness anxiety disorder, also known as hypochondriasis. Before we talk about each of these disorders separately, let's talk about what is common among all of these diagnoses. In contrast to malingering and factitious disorders, somatic symptom and related disorders are characterized by unconscious motivation and unconscious symptoms. In other words, The patient with somatic symptom and related disorders does not know why he or she has the symptoms, and this patient does not inflict the symptoms on himself or herself. So there are some unexplained symptoms which are not fabricated or caused intentionally. And the fact that these symptoms are unexplained gives very significant distress and impairment in the social life to the patients with these disorders. Now let's talk about the somatic symptom disorder first. It is also known as somatization disorder. Somatic symptom disorder is characterized by at least one somatic symptom or bodily symptom which lasts for more than 6 months. Usually, the symptoms in the patients with somatic symptom disorder are very vague. These symptoms usually include either non-specific headache. This may also be just fatigue or generalized tension in the body. This may also be a non-specific abdominal pain, which lasts for months or even years. Now, when the patient with somatic symptom disorder goes to the physician, then after undergoing multiple diagnostic tests, physicians usually cannot diagnose the reason for the patient's symptoms because these symptoms have psychological origin. And this fact gives those patients even more anxiety. Can you imagine having a symptom or a complaint that nobody can explain? And can you imagine living with this symptom for years? This definitely gives them excessive anxiety and persistent thoughts. So they may be paralyzed by thinking about their symptom. Thoughts about these symptoms may interfere with their work, with their family relationships, with every aspect of their life. But please don't get me wrong. Don't think that patients with somatic symptom disorder cannot have the concomitant medical illness. They absolutely can have it. And the treatment for patients with somatic symptom disorder is to have the regular visits with the same physician. Idea here is that the patient can go from one physician to another and to another with the hope that the other physician will diagnose his or her problem. But it's much better to make them attach to one physician who knows his or her symptoms really well. This will save the unnecessary medical expenses, and this will save the patient's time and money as well, right? Additionally, the patients with somatic symptom disorder need psychotherapy because they need to realize that their symptoms are psychological in origin and their symptoms may signify the unresolved emotional conflicts that they need to deal with. But here's the thing. We cannot be confrontational with these patients. We cannot say that, oh, all of these comes from your head and you need to deal with it or you need to overcome that. This is absolutely unethical and absolutely wrong because when somebody says these words to a patient, this patient will at least leave that physician and will go to another physician for further testing and hope to find out what's causing the symptoms. We need to be very careful with these patients and we need to gradually make them understand the psychological nature of their bodily complaints. Okay, now let's move on to the conversion disorder. Conversion disorder is also known as the functional neurological symptom disorder. This is when the patient develops an unexplained acute neurological signs and symptoms. But again, it's functional neurological symptom disorder. In other words, those neurological deficits are functional. There is nothing There's no anatomical defect, there's no physiological defect that could explain the patient's neurological deficit. It's functional, and it usually occurs after an acute, severe stressor. Let's take an example. Let's say that the family member of a patient died unexpectedly in a car crash, or died unexpectedly from a medical illness, let's say myocardial infarction. This can be so stressful that this event can actually induce the functional neurological symptom disorder in another family member. And the symptoms usually include either paralysis of the body, it may also be mutism or blindness. Here's the thing, the patient may be aware of their own symptoms, but the patient will be indifferent toward the symptoms. This phenomenon is known as label indifference. Pardon my French. I don't know French, so I don't know if I'm pronouncing this term correctly. But label indifference means that the patient is indifferent towards his or her symptoms. Although the questions on the USMLEs use this notion of label indifference with regards to conversion disorder, I'd like you to know that label indifference is a non-specific phenomenon. This can also be observed in other psychological or non-psychological medical illnesses. Okay, and finally, conversion disorder is much more common in adolescents, young adults, and females as well. And finally, we have the illness anxiety disorder, also known as the hypochondriasis. This is when you are constantly anxious about having or acquiring an illness. This is why it's called illness anxiety disorder. These are the patients who think that they have some very serious or deadly disease if they just have one characteristic symptom. I don't know, let's say that the patient has slightly enlarged gums and has the bleeding from the gums, and then that patient comes to the doctor and says that he or she has definitely has a leukemia, because that patient has read that leukemia can cause the enlargement of the gums and bleeding from the gums, right? But gum enlargement and bleeding can be caused by so many different things before we even think about leukemia. So again, these people are preoccupied with their own health and with the thoughts that some disease is either already present or is going to be present in their body. Unfortunately, patients with illness anxiety disorder are not often reassured even after the medical evaluation and sufficient reassurance. They simply cannot stop worrying about their symptoms. And in terms of symptoms, they may truly have some mild, non-significant symptoms, or they may have absolutely no symptoms. Okay, we have talked about malingering, factitious disorder, and somatic symptom and related disorders. Now let's summarize these three disorder clusters according to the motivation and symptoms. As we already mentioned, malingering is characterized by intentional motivation and intentional symptoms. In other words, you know why you have the symptoms, you know why you are inflicting the symptoms, and you also realize that you are the one who is inflicting the symptoms. In case of factitious disorder, you know that your symptoms are intentional, but your motivation is unconscious. In other words, you know that you're the one who is inflicting those symptoms, but you don't know why you're doing this. And finally, patients with somatic symptom disorder have unconscious motivation and unconscious symptoms, which means that they don't know why they have the symptoms, and they are not the ones who inflict the symptoms. Symptoms come on their own, and they cannot explain what causes these symptoms. Okay, now that we have talked about these disorders, let's move on to the eating disorders. Our next topic is the eating disorders, And in this subsection, we'll talk about the anorexia nervosa, bulimia nervosa, binge eating disorder, pica, and avoidant restrictive food intake disorder, or ARFID. Let's start with anorexia nervosa. And before we do this, let me tell you one thing. Almost all eating disorders are most common in young females, either adolescents or young adults. In anorexia nervosa, the patient is terrified of gaining weight. Their primary drive and the reason why they develop this disorder is that they are afraid of gaining weight. And additionally, they have distorted body image. What I mean here is that although they are very slim and very thin, they think and they feel like they are either overweight or obese and they need to lose more weight. And you can imagine that this mindset and the fear of gaining weight results in a very low body weight. So specifically, the BMI of anorexic patients is usually less than 18.5. The normal BMI range has been modified recently. Now it's 19 to 25 rather than 18.5 to 24.9, but still, patients with anorexia are severely malnourished. And anorexia nervosa can be accompanied by many comorbidities. The patient can have hypothyroidism just due to the fact that the patient does not get enough iodine and the nutrients necessary for thyroid hormone synthesis. The patient can also have amenorrhea and osteoporosis due to functional hypothalamic amenorrhea. The idea here is that the adipose tissue produces leptin. The leptin stimulates pulsatile GnRH secretion from the preoptic nucleus of the hypothalamus. And we know that we need the GnRH in order to keep the hypothalamic pituitary gonadal axis going. Now let's imagine that the patient has anorexia nervosa. In that case, the patient has a very small amount of body fat. Therefore, the serum leptin levels also decreases. Low leptin causes cessation of pulsatile GnRH secretion. And if there's no GnRH, then there's no FSH, LH, and estrogen, which means that the patient will develop amenorrhea and osteoporosis because estrogen, as we have talked in the musculoskeletal series, has a protective effect on the bone and it increases the bone mass. Additionally, patients with anorexia nervosa have Lenugo hair. Lenugo hair is different from the terminal hair in that it is fairly colored and it's very gentle and very fragile. It's a baby hair. And again, the idea here is that everything in the body is devoid of enough nutrients, including the body hair. Therefore, the body hair is very thin and very fragile. Anorexia nervosa, surprisingly, can also be accompanied by hypercholesterolemia and hyperkeratinemia. Okay, now there are two main types of anorexia nervosa. It's binge eating purging type and the restricting type. Now, binge eating purging type of anorexia nervosa, as the name implies, is characterized by episodes of binge eating and purging. So purging behavior is the behavior which gets rid of those calories that were obtained during the binge eating episode. And the purging behavior can include the laxative abuse in order to induce diarrhea. It can also include the diuretic abuse and also self-induced vomiting. The important thing about anorexia nervosa is that the signs and symptoms of this disorder should be lasting for at least 3 months in order to diagnose the patient with anorexia nervosa. And that's true for all the eating disorders except for the pica. So, anorexia nervosa, bulimia nervosa, and binge eating disorder have the time cutoff value of the 3 months. but pica has the time cutoff value of 1 month, and we'll get back to this concept once we move on to the other eating disorders. Okay, binge eating purging subtype of anorexia nervosa is not the same as bulimia nervosa. We'll definitely discuss bulimia nervosa in detail, in short, but let me compare and contrast bulimia nervosa and binge eating purging type of anorexia nervosa. When we talk about the anorexia nervosa with binge eating and purging, the patient still has a very low BMI, usually less than 18.5. In contrast, the bulimia nervosa patient usually has either normal BMI, anywhere from 19 to 25, or even the BMI of an overweight patient, from 25 to 29.9. That's basically the main difference between binge eating purging type of anorexia nervosa and bulimia nervosa. Now, the second type is the restricting type. And it's called restricting type because patients with this subtype of anorexia nervosa completely restrict the caloric intake. In other words, you can think of them as having only the purging behaviors without the binge eating episodes. They are into excessive dieting and fasting and over exercising as well. But there is no binge eating episode in this case. Now, restricting type of anorexia nervosa should be compared to avoidant restrictive food intake disorder. The patient with ARFID, or avoiding restrictive food intake disorder, does not eat food because she does not like the experience of eating. She does not like how the food feels like in her mouth. She does not like the texture and the consistency of food. So, to summarize, patients with avoidant restrictive food intake disorder are afraid of the experience of eating, and at the same time, they are afraid that if they eat, they may vomit. But in case of restricting type of anorexia nervosa, the patients restrict the caloric intake not because they are afraid of the experience of eating, but because they think that they are overweight or obese. Okay, now let's talk about the treatment of anorexia nervosa. In almost all eating disorders, nutritional rehabilitation and psychotherapy are the first line management options. And then, if nutritional rehabilitation and psychotherapy are not enough for patients with anorexia nervosa, then we can use olanzapine. I know we haven't covered psychopharmacology yet in our course, but could you please tell me what drug olanzapine is? Freaking-lutely. Olanzapine is a second generation antipsychotic, and due to its antihistamine and antimuscarinic effects, it has the side effect of gaining weight and increasing the appetite. So, olanzapine can be particularly helpful in patients with very severe anorexia nervosa who need to gain weight. There is one very high yield condition we need to mention about in regards to the nutritional rehabilitation, and this is refeeding syndrome. Refeeding syndrome occurs when we suddenly increase the caloric intake to the normal level in a patient who is severely malnourished. When we say severely malnourished, we don't only mean the patients with anorexia nervosa. This can be, let's say, an alcoholic patient with insufficient food and chronic malnourishment, or this can be, let's say, the child with marasmus or kwashiorkor syndrome. Anyone who is chronically malnourished are at risk for refeeding syndrome if we suddenly increase their caloric intake to the normal levels. Let's explain the pathophysiology of refeeding syndrome. when the patient is chronically malnourished and then we increase the caloric intake, we suddenly increase the serum glucose levels. Well, when the serum glucose levels increase, then we have a corresponding insulin surge. But in this case, insulin surge is excessive because the body has been malnourished and now it has been exposed to lots of calories and lots of glucose. Insulin has the ability to shift certain electrolytes into the cells. And these electrolytes and ions include phosphate, potassium, and magnesium. So if insulin shifts the phosphate, potassium, and magnesium from the serum into the cells, then the patient with refeeding syndrome will have hypophosphatemia, hypokalemia, and hypomagnesemia. Additionally, the insulin can shift the thiamine or vitamin B from the serum into the cells. So if the patient has refeeding syndrome, then the patient will have low serum thiamine levels. Now let's explain the symptoms and relate those symptoms to the electrolyte and nutrient disturbances in the blood. Patients with refeeding syndrome can have arrhythmias and the other cardiac complications. And this is mostly related to hypokalemia. As we know, both hypo and hyperkalemia can predispose the patient to the arrhythmias. At the same time, patients with refeeding syndrome may have the rhabdomyolysis. Rhabdomyolysis is the breakdown of the skeletal muscle. The idea here is that serum phosphate is depleted. If there is insufficient serum phosphate, then the muscles can no longer make enough ATP. If there is insufficient ATP inside the muscle cell, then the pumps on the muscle membrane fail. The simplest pump is the sodium-potassium pump. So if the pumps fail, this will disturb the osmotic gradient between the cell and the extracellular fluid, and the cells will swell up because they start to accumulate sodium. And when the cells swell up, they may rupture and cause the rhabdomyolysis. And finally, patients with refeeding syndrome can also have the seizures due to combination of all the electrolyte disturbances and especially hypomagnesemia. If thiamine deficiency induced by refeeding syndrome is very severe, this can bring the Wernicke's encephalopathy to the patient's overall status. And as we know, Wernicke's encephalopathy is characterized by confusion, ataxia, and ophthalmoplegia. Okay, now that we've talked about refeeding syndrome, let's move on to bulimia nervosa. In bulimia nervosa, the patients do not have the distorted body image. In bulimia nervosa, the patients have uncontrolled binge eating episodes, and then they feel bad about themselves, which is why they purge. What I'm trying to say here is that the main disturbance in bulimia nervosa is this binge eating episodes, which is followed by the compensatory purging behaviors. We already mentioned that bulimia nervosa is characterized by symptoms for at least weekly, over at least 3 months. Again, what differentiates bulimia nervosa from the binge eating purging type of anorexia nervosa is the BMI. Patients with bulimia nervosa usually have a normal BMI, or they may also be slightly overweight. Just like we talked about the complications of anorexia nervosa, let's discuss the complications of bulimia nervosa. Bulimic patients commonly have the parotid gland hypertrophy. This is because they commonly use self-induced vomiting as the purging behavior. And if they vomit many times, the acid in the oral cavity is a stimulus for parotid gland hypertrophy. This is why parotid glands may be hypertrophied in bulimia nervosa, and this can also be evident by increased serum amylase. As we know, amylase is present in the saliva and it's produced by the salivary glands, right? So serum amylase can increase in the setting of parotid gland hypertrophy. Patients with bulimia nervosa can also have enamel erosion. Well, their teeth is constantly exposed to the gastric acid, and the acid can demineralize the enamel. So this is why we'll see the discolored and yellowish teeth. Bulimic patients are at risk for Mallory-Weiss syndrome. Again, this comes from the vomiting, because when they vomit, they may increase the lower esophageal pressure to the point where the pressure induces the longitudinal lacerations at the gastroesophageal junction, otherwise known as the Mallory-Weiss syndrome. Bulimic patients also have electrolyte and acid-base disturbances from vomiting. Let's think about this. When the person vomits, he or she vomits the gastric acid, which is hydrochloric acid. If you vomit the chloride ions, then you will have hypochloremia. Additionally, if you vomit acid, which is in this case hydrochloric acid, then you will have less acid and more base in your body, so you will have metabolic alkalosis. But there's another explanation for metabolic alkalosis in patients with regular vomiting. When you vomit, you deplete yourself of the volume. And low plasma volume activates the renin-angiotensin-aldosterone system. And when this system is activated, this can induce metabolic alkalosis. We won't go into detail of how it can do this because this will take time and it's beyond the scope for this particular discussion, but still, renin-angiotensin-aldosterone system can induce metabolic alkalosis, and it can also induce hypokalemia due to aldosterone. So, to summarize, patients with vomiting can have hypokalemic, hypochloremic metabolic alkalosis. And finally, patients with self-induced vomiting commonly have the dorsal hand calluses on their knuckles. This is called Russell sign. So when you induce vomiting, and if you put your fingers into your oropharynx, then the teeth will rub against your knuckles, and this will cause the calluses on your knuckles, also known as the Russell sign. Again, the treatment for bulimia nervosa, just like for any other eating disorder, is psychotherapy and nutritional rehabilitation as the first line. Antidepressants, for example SSRIs, can also be used in bulimia nervosa. Here comes probably one of the highest yield concepts related to bulimia nervosa in psychopharmacology. Do you know which antidepressant is absolutely contraindicated in anorexia nervosa and bulimia nervosa? You are crazy smart. Exactly, that's bupropion. The reason why bupropion is contraindicated is that bupropion itself decreases the seizure threshold. In anorexia nervosa and bulimia nervosa, the patients commonly have electrolyte abnormalities, which also decreases the seizure threshold. So if you add bupropion to the patient's regimen, to the regimen of the patient with anorexia or bulimia, this can certainly induce the seizures. Okay, we have done discussing the bulimia nervosa as well. Now let's move on to binge eating disorder. The name here explains everything that we need to know about this disorder. Patients have the episodes of binge eating without purging behavior. This is in contrast to bulimia nervosa and to binge eating purging type of anorexia nervosa. These people have the episodes of overeating, but they don't purge. They don't abuse laxatives or diuretics. They don't induce vomiting. They don't over-exercise or diet or fast. And this should also happen at least weekly over the last 3 months. You can imagine that if a person has these binge eating episodes without purging, then his or her weight will increase exponentially. Therefore, it will increase the risk for overweight and obesity. And finally, it will increase the risk for diabetes as well. Binge eating disorder is actually the most common eating disorder in adults. The treatment for binge eating disorder is psychotherapy. That's the first line treatment. But if psychotherapy alone doesn't help, then we can use SSRIs. And finally, we can also use lisdexamfetamine as a last resort. Lisdexamfetamine is the modified version of amphetamine. What I'm trying to say is that lisdexamfetamine is a CNS stimulant. And if you remember, CNS stimulants have the side effect of appetite suppression. And in the patient with binge eating disorder, we make use of that side effect and we make it something useful. So we try to pharmacologically suppress the appetite of the patient with binge eating disorder. Fine. Now the last eating disorder that we're going to discuss is pica or pica, however you want to call it. Pica is when the person eats non-food substances for at least 1 month, and eating the non-food substances are not culturally normal or developmentally recognized. What I mean here is that the late infants or toddlers may unintentionally eat a non-food substance like hair or the paint chips, but this is normal for their developmental age. If the child, adolescent, or adult starts to eat the non-food substances and it's not culturally recognizable, then we can consider pica as the possible diagnosis. The substances that are commonly ingested in patients with pica include the ice, hair, dirt, or paint chips. It's really common in children and also during the pregnancy. And there are certain risk factors associated with the development of pica. First, malnutrition can induce pica. The idea here is that if the patient is chronically malnourished, then the patient starts to look for the calories and vitamins and minerals in non-food substances. Iron deficiency anemia is also characterized by the tendency of the patient to develop pica. Patients with developmental disabilities are prone to develop pica because they may eat non-food substances. And finally, someone with emotional trauma can develop pica as well. So now you can see how many risk factors can contribute to pica. It can be based on emotional disturbances and psychological conflicts. It can be simply due to malnutrition or iron deficiency anemia, and it can also be due to developmental or intellectual disabilities. The treatment for pica is psychotherapy, especially if it's based on the psychological conflicts, and nutritional rehabilitation. Now, if psychotherapy and nutritional rehabilitation don't work, then we can use the SSRIs. So SSRIs are the second line treatment for pica. Okay, now we're done with the eating disorders. Now we'll discuss the gender dysphoria. Gender dysphoria is incongruence between one's experienced gender and the assigned gender or the physiologic gender. In other words, if we have a male patient who has an assigned gender of a male but feels like a female inside, that's the gender nonconformity. And we'll definitely talk about the difference between gender dysphoria and gender nonconformity. Now here's the thing, gender dysphoria should last for more than 6 months. And in order to diagnose the patient with gender dysphoria, the incongruence between gender identity and assigned gender should cause persistent distress and an impairment in occupational and social functioning. And that's the difference between gender dysphoria and gender nonconformity. If you feel like the opposite gender, but you are totally fine with the way you feel, and if it doesn't really cause any impairment in your life, then it's just gender nonconformity. But gender dysphoria is when you are stressed out and when you don't have enough support to feel safe and heard and secure with your real gender or gender identity. The patients with gender dysphoria may not only self-identify as the opposite gender, but they may also go for the gender affirming surgery, or they may change the way they live, the way they look, the way they dress. They may also go with the hormonal therapy to live like the opposite gender. The gender nonconformity itself is not a mental disorder at all. And on a side note, shout out to all the people from LGBTQIA plus community, because you are beautiful the way you are, and I will support you and I will fight for for your rights, as well for the rights of all the other people. Okay, so back to our topic. Gender dysphoria can manifest really early in life. The reason being is that gender identity usually develops at around the age of 3. And here's the thing. If, let's say, the boy tries to play with the dolls or the Barbie houses, and if it happens once or twice, that does not mean that the patient has gender dysphoria, because the child is experimenting with the different toys and with the different roles. It does not indicate any diagnosis. But if you see that the child consistently wants to play with the toys that are historically considered to be female toys, or if the child likes to dress up like a lady, then you can consider that the child may have gender nonconformity. Okay, let me also define the term transgender for you. So transgender is the person who has gender nonconformity. It's that. What I'm trying to say here is that one doesn't have to pursue the gender affirming surgery or hormonal therapy, and one doesn't have to change anything in their appearance in order to be classified as a transgender individual. If you feel like the opposite gender and you want to live like an opposite gender, you are a transgender regardless of whether you change anything in your appearance. The transgender is absolutely different from the term transvest or transvestism. I have seen some people who confuse these terms, so I also want to compare and contrast these terms for you. Transvest individual is a cross-dresser. This is someone who enjoys dressing the opposite gender's clothes in order to arouse sexually. However, they don't have the gender nonconformity. Let's say that there is a male person who is a transvest. It means that he likes to dress with the women's clothes to get sexually aroused. However, his gender identity is male. He identifies himself as male, and he likes the females. So again, transvestism means cross-dressing in order to obtain the sexual arousal. Okay, now that we've talked about the gender dysphoria, I'd like to discuss the sexual dysfunction with you. Sexual dysfunction is not the same thing as erectile dysfunction. Sexual dysfunction is a much broader term. It's an umbrella term which involves all the diagnoses and all the dysfunctions related to the sexual intercourse. In order to comprehend all types of sexual dysfunction, we need to first talk about the different phases of sex. Before the sex starts, there is sexual desire or desire for sex. After the intercourse starts, the first phase of the sex is sexual arousal. This is the phase of, let's say, kissing and maybe the oral intercourse as well. After the sexual arousal phase, then there is the plateau, which is the actual sex. After the plateau, then there is an orgasm, and after orgasm, there is resolution. The reason I'm emphasizing these different phases of sex is that the different types of sexual dysfunction can be mapped to the different phases of sex. Let's start with the sexual desire disorders. We have two diagnoses in this subgroup. This is hypoactive sexual desire and sexual aversion. Hypoactive sexual desire literally means that the person is not as interested in sex as an average person. It doesn't mean that the patient doesn't have a sex life. He or she may have a sex life, but again, this patient has less than normal interest and desire for sex. Now, sexual aversion means that the patient hates even the thought of having sex with someone, and they may feel that having sex or thinking about sex is something to be embarrassed or ashamed of. Therefore, patients with sexual aversion may need the psychotherapy so that they realize that sex is totally fine and it's totally normal. There is nothing to be embarrassed about or ashamed of about either thinking or having sex. During the sexual arousal phase, the major sexual dysfunction disorder is the erectile dysfunction. And at the end of this subsection, we'll definitely talk about the differential diagnosis of the erectile dysfunction. Now let's move on. During the plateau, we mostly have the sexual pain disorders. And there are two main diagnoses here. This is dyspareunia and vaginismus. You may ask me what the difference is between dyspareunia and vaginismus. Well, dyspareunia is a very broad term. It literally means painful sexual intercourse, but dyspareunia can be caused by multiple different disorders. Let's say it can be genital urinary syndrome of menopause, also known as atrophic vaginitis. It can be caused by endometriosis. I don't know, it can be caused by adenomyosis. So many different gynecological conditions can induce dyspareunia. But vaginismus is a very discrete and very specific diagnosis. It's also known as genitopelvic pain penetration disorder, so GPPPD. This is when the penile penetration or any penetration into the vagina stimulates very strong and very intense muscle contractions, and this causes pain and inability to penetrate during the sex. During the orgasm, we have orgasmic disorders. And again, there are two disorders in this subgroup. There is anorgasmia, when the patient does not have orgasm at all. And then there is premature ejaculation, which means that ejaculation happens really soon after the plateau phase of the sex starts. If you remember, we have mentioned that SSRIs can cause either erectile dysfunction or anorgasmia as their side effects. Therefore, if the patient has premature ejaculation, this patient can actually benefit from SSRIs because SSRIs will delay time until ejaculation. Okay, now we have talked about almost all sexual dysfunction disorders along the time frame of sex. And what I'd like to discuss with you now is the differential diagnosis of the erectile dysfunction. The way we can remember these causes is by the mnemonic penis. Each letter in the word penis stands for the different cause of the erectile dysfunction. P stands for psychological erectile dysfunction. The psychological erectile dysfunction is characterized by the intact nighttime or early morning erections. As we know, the early morning tumescence, which is incomplete erection, is totally normal in both males and females, and it's caused by increased acetylcholine during the REM sleep. Now, if the patient has psychogenic erectile dysfunction, which means that the erectile dysfunction is caused by psychological stressors, then morning erections will be maintained because when you sleep, you likely don't have the psychological stressors. Therefore, the patient still has the erections. Now, if the patient does not have the nighttime or early morning erection, then we know that the erectile dysfunction is not psychogenic. And we need to think about the organic causes of the erectile dysfunction. Now, the second letter E in the mnemonic penis stands for endocrine diseases, for example, diabetes or low testosterone. As we know, diabetes induces very significant changes in the vessel walls. Specifically, it causes hyaline arteriolosclerosis, and hyalinization of the vessels narrows down the vessels. So if you have narrowed vessels in the corpora cavernosa, it means that you have insufficient blood flow into the penis, which will result in erectile dysfunction. A low testosterone can certainly cause the erectile dysfunction because testosterone determines the patient's libido, simply saying the desire for sex, and it's also necessary for the erection. The letter N in the mnemonic penis stands for neurogenic erectile dysfunction. This is when the damage to the nervous system, specifically the spinal cord, induces the erectile dysfunction. This can be postoperative neurogenic erectile dysfunction, or it can occur after spinal cord injury. Now, the letter I stands for insufficient blood flow. And here we mean the peripheral arterial disease, right? So if the patient has extensive atherosclerosis, again, this will narrow down the vascular lumen, and this will decrease the blood flow into the corpus cavernosum, and it will induce the erectile dysfunction. And finally, S stands for substances. So different medication and substances can induce erectile dysfunction. Many antihypertensive drugs, especially beta blockers, can induce erectile dysfunction. Antidepressants can also cause erectile dysfunction. We have just talked about how SSRIs cause either erectile dysfunction or anorgasmia. And finally, excessive alcohol intake also inhibits the erection, and it can cause the temporary erectile dysfunction. Okay, we have talked about sexual dysfunction, and now we'll move on to sleep terror disorder. The sleep terror disorder is when the patient has very severe, inconsolable terror with screaming and crying in the middle of the night. Sleep terror disorder is more common in children than in adults. And the sleep terror episodes occur during the slow wave sleep or the deep sleep. Slow wave or deep sleep is the third stage of the non-REM sleep. We are not going to discuss the sleep physiology here in Psychiatry series because it's the topic for the neuroscience series. However, let me tell you one thing. During the REM sleep, our brain is on, but our body is off. Meaning, in a normal person with the normal REM sleep, the brain is working almost like an awake brain, but the patient cannot move. He or she is normally paralyzed. In contrast, the non-REM sleep is characterized by the brain that's off and the body is on, which means that brain has a very slow frequency of the wave. So we have the delta frequency. Well, it depends on the stage of the non-REM sleep, but still, the brain is not working as the awake brain, but the body can move. Body is not paralyzed. And now you can imagine that during the sleep terror, the patient can wake up or sit up in the bed and scream. But then, since the brain has low activity during the non-REM sleep, the child or any patient does not remember about the sleep terror episode. This is a very important distinguishing factor between the sleep terror and the nightmare. The nightmares, and in fact all the dreams, occur during the REM sleep. As we mentioned, during the REM sleep, brain is on but body is off, which means that if you have a nightmare or any other dream, you most likely remember that dream because the brain is working almost like an awake brain in your REM sleep. Okay, to summarize, sleep terror, you don't remember the sleep terror episode. Nightmare disorder, you remember the nightmare because it happens during the REM sleep. There are several triggers for the sleep terror disorder. Fever, lack of sleep, and any type of emotional stress can induce sleep terror in a child. And a very, very important thing about sleep terror is that it's a self-limited diagnosis. In other words, it will go away on its own as the child is getting older. In other words, you don't need to initiate any type of treatment for the sleep terror disorder. There are several drugs and substances which shorten the N3 sleep. For example, alcohol, benzodiazepines, barbiturates, and norepinephrine, sorry, not norepinephrine, but all those CNS depressants can shorten the N3 sleep. But you don't have to give benzodiazepines or even barbiturates to the patient with sleep terror disorder. It just goes away on its own. Okay, now let's discuss enuresis briefly. Enuresis is nighttime urinary incontinence, which has a very specific time frame and the age cutoff. The way I remember the time frame and the age cutoff for the enuresis is by this. 2 plus 3 is 5. So we have three numbers here. This is 2, 3, and 5. Urinary incontinence should be happening at least 2 times per week for at least 3 months in a person more than 5 years old. So again, 2 plus 3 equals 5. Enuresis can be either primary or secondary. Primary enuresis means that the child has never been dry for more than 6 months, while secondary enuresis means that although the child has had an episode of dryness for more than 6 months, now he or she has resumed to wet the bed. Regardless of what type of enuresis we have, we should absolutely order the urinalysis to rule out the urinary tract infection as the cause of the enuresis. Now, the first line treatment for enuresis is behavioral modification and positive reinforcement techniques. In behavioral modification, we mean the nighttime fluid restriction and the scheduled voids so that the child does not wet bed at night. In positive reinforcement techniques, we mostly mean the star chart therapy. You can hang a star chart near the patient's bed, and for every single dry night, you give 1 star to the child on every morning. And this definitely works like a positive reinforcement, right? Here we use the operant conditioning as the basis of this technique. Now, if behavioral modifications and positive reinforcement don't help, then we can move on to second line management option, which is a bedwetting alarm. Bedwetting alarm is a specific alarm placed under the bed, and whenever the child starts to wet the bed, the alarm goes off, and child wakes up and goes to the bathroom to pee. And this technique makes use of the classical conditioning. So in that case, the alarm sound is an unconditioned stimulus, and waking up is unconditioned response. Now, if you wake up every time you want to pee while the alarm is ringing off, it means that the desire to urinate becomes a conditioned stimulus and waking up becomes a conditioned response. If the bedwetting alarm still doesn't help, then we can go to the medications, and the preferred medication for enuresis is the desmopressin, oral desmopressin. Desmopressin is the vasopressin analog. It's the antidiuretic hormone analog. The idea here is that ADH reabsorbs the free water from the collecting tubule, and the child decreases the urine production at night. This is how desmopressin can help with enuresis. And the last resort treatment, which is used very, very rarely, is imipramine. Imipramine is a tricyclic antidepressant, and it can be used in enuresis because it has very strong antimuscarinic properties. If you block the M3 muscarinic receptors on the detrusor muscle of the bladder, then the bladder can no longer contract and the patient will not wet at night. Right, this was the enuresis. Now, let's move on to narcolepsy. Narcolepsy is associated with excessive daytime sleepiness despite waking up well rested. And I'm emphasizing this point because we need to compare and contrast the narcolepsy and the sleep apnea, let's say obstructive or central sleep apnea. When the patient has sleep apnea with recurrent episodes of awakening during the night, then the patient wakes up unrefreshed because they don't have a continuous normal sleep. In case of narcolepsy, they usually sleep normally and they wake up well rested, but during the daytime they have this excessive sleepiness, and they may also have the rapid onset sleeping episodes. The narcolepsy also has its time frame. The symptoms should be present at least 3 days per week for at least 3 months. There is a clear physiological cause for narcolepsy. Narcoleptic patients are characterized by low orexin concentration or hypocretin concentration coming from the lateral hypothalamus. Orexin or hypocretin is the neurotransmitter which keeps us awake, which keeps us conscious. Now, if orexin, also known as hypocretin, is low, it means that we cannot stay awake and we fall asleep. And orexin is produced in the lateral hypothalamus. Now, narcolepsy is characterized by several high-yield clinical features. First, it's characterized by hallucinations, which can be either hypnagogic or hypnopompic. Hypnagogic hallucination is the one that happens just immediately before falling asleep. The way you can remember this is by first a mnemonic saying hypnagogic is while going to bed. In contrast, the hypnopompic hallucination happens immediately after waking up. Again, the first aid has the mnemonic for this. So a hypnopompic hallucination is while you get pumped up in the morning. So it's at the verge of awakening. Sorry, I was incorrect when I said that hypnopompic hallucination happens immediately after awakening. It happens just before the awakening. And both hypnagogic and hypnopompic hallucinations can have any nature. So they can be auditory hallucinations, visual or tactile hallucinations. Any type of hallucination can qualify for that. Patients with narcolepsy also have the episodes of sleep paralysis, which can happen either during the night or during the daytime. Sleep paralysis is when the sleep starts with the REM episode or the REM sleep. In other words, the REM latency of the patients with narcolepsy is super small. REM latency is the time between the onset of sleep and the onset of the REM sleep. Now, if narcoleptic patients go into REM sleep immediately while going to sleep, then the REM latency can even be zero, right? As we already mentioned, REM sleep is characterized by brain that's on but the body that's off, which means that you are paralyzed, you cannot move, but your brain works almost like an awake brain. And this is what sleep paralysis is all about. Sleep paralysis is the REM sleep episode with an intact awake consciousness. You hear everything, you feel everything, and you see everything, but you cannot move. The sleep paralysis itself is not pathognomonic for narcolepsy. I have heard patients and people talking about the sleep paralysis episodes, but they don't have narcolepsy. What I'm trying to say is that if the patient has just the episodes of sleep paralysis and it happens just once or twice, then this is definitely not enough to diagnose that patient with narcolepsy. And the final important feature of narcolepsy is something called cataplexy. Cataplexy is when the patient suddenly loses all muscle tone after a very strong emotion. It's usually laughter, but literally any emotion can trigger cataplexy. Please don't confuse cataplexy with catalepsy. Catalepsy is the part of catatonia, and it means statuing of the patient. So as we know, in catatonic patient, you can literally change their posture in any way you want, and they may even maintain that posture for a long time against the gravity. That's called catalepsy, but cataplexy is what we already discussed. That's sudden loss of muscle tone after strong emotion, characteristic for narcolepsy. Now, the question is, how do we treat narcolepsy? Well, first, the person needs very good sleep hygiene. Sleep hygiene means that the daytime naps should be scheduled and the sleep schedule should be regular as well. In other words, the person should go to bed and wake up at the same time every day. In order to combat this daytime sleepiness, we can use the daytime stimulants, whether it's amphetamines or modafinil. And the nighttime drug that can be used in narcolepsy is sodium oxybate, abbreviated as GHB. It's abbreviated as GHB because it's gamma hydroxybutyrate. It's the modified version of the chemical GABA. As we know, GABA or gamma aminobutyric acid is a depressant neurotransmitter, so it decreases the CNS functions. And this is what sodium oxybate also does. Sodium oxybate is shown to decrease the frequency of the cataplexy episodes during the daytime. The only downside of this medication is that you need to wake up multiple times during the night to take the sodium oxybate. Okay, this was our discussion about the narcolepsy. Now let's move on to general overview of this substance use disorder. We are not going to talk about the different substances here, definitely not, because our episode is already lasting long. So we are just going to define when to diagnose the patient with substance use disorder. There are 11 criteria which suggest the substance use disorder. And in order to diagnose the patient with substance use disorder, the patient must meet at least 2 out of these 11 criteria for at least a year. Now, the first criteria is tolerance, which means that the patient needs more and more of the same substance to feel the same level and same extent of pleasure. The second criteria is withdrawal, meaning if the patient does not get exposed to the substance for a long time, then she or he gets the symptoms of withdrawal, and all the substances have the different manifestations of withdrawal. Another criterion is the intense distracting cravings. If your craving for the substance is so intense that you cannot concentrate on anything else, that can suggest a substance use disorder. The fourth criterion is when you use the substance more or longer than intended. At the same time, if you have desire to cut down the substance, but you cannot cut down the substance, that's another criterion suggesting the substance use disorder. The patient with substance use disorder may involve in time-consuming substance acquisition. In other words, even if the patient has to travel a long distance to obtain the substance, he or she will do that with the hope that they will obtain the substance. It's no surprise that patients with substance disorder may have impaired functioning at the different environments, so at work, at school, at home. This can also induce the interpersonal conflicts, which is another criterion, right? Yeah, and then the ninth criterion is reduced recreational activities. In other words, if you'd rather stay home using your substance rather than going out with your friends and hanging out with them, this may suggest that you have substance use disorder. Additionally, if the patient uses the substance in the dangerous circumstances, like driving at high speed or having an unsafe sex, this may indicate that the patient suffers from the substance use disorder. And finally, if the patient continues to use the substance despite being aware of all the risks associated with that substance, that is the last 11th criterion. And again, as we mentioned, the patient should meet at least 2 out of these 11 criterion for the past year. In the question stems, you don't necessarily have to count how many criteria the patient meets, because if they want to describe a patient with substance use disorder, then this patient will certainly have more than 2 criteria fulfilled, and therefore you will understand, automatically know that the patient has substance use disorder. Okay, and the final last topic for our discussion today is the gambling disorder. I'm sure that the name itself explains almost everything that we need to know. This is also known as pathological gambling. This is the recurrent and problematic gambling. Patients with gambling disorder are preoccupied with gambling. They think about gambling, and nothing else. At the same time, they constantly want to increase the size of their bet in the hope that they will win more money. Gambling disorder is also characterized by the unsuccessful attempts of the patient to stop gambling. They are literally addicted to gambling. Additionally, these patients have gambling as the coping mechanism to escape the stressors. If something goes wrong in their life, if they are upset, if they are hurt, they might go to the casino to gamble because this is what may calm their nerves. And finally, if they lie to their family or if they lie to their therapist to hide how much addicted they are, this also indicates that the patient suffers from the gambling disorder. The last point I want to make is that psychotherapy is the treatment, but we should not confuse the gambling disorder with just regular gambling. I know the family, I know people who like to gamble. They go to casino once in a while, but they absolutely control the money that they bet, and they control their lives. So they have children, they raise them up, and they are financially stable. And this is not considered as pathological gambling or gambling disorder. Again, the baseline in psychiatry is that something is called disorder when it interferes with the normal functioning of an individual. And this rule definitely spreads to the gambling as well. Okay, we have come to an end of our today's episode, so let's summarize everything that we've discussed today.